Welcome back, everyone, to our Research Connect series. My name is Stephen Uriaku, a CDTRP trainee. I'll be facilitating today's webinar. I'm a third-year doctoral candidate at the Philosophy Department, University of Ottawa, and my research is on the rules for and the problem of trust in organ transplantation, acquisition, and allocation. Uh, First, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I would also like to acknowledge Estella's, whose generous support we could not have had to host these sessions without. And before we dive into the main content, I will pass it to Erica for some general CDTRP updates.
Thank you, Stefan. Today I have two announcements. The first is to mention that registration for our annual scientific meeting is now open. This year's meeting will take place in Calgary on December 3rd and 4th. On December 2nd, CDTRP researcher Dr. Lorraine Hamuka is hosting a symposium on pediatric transplantation, coined the Gardner Symposium. If you're planning to travel, why not extend your stay and attend both? Registration links will be added to the chat momentarily. Thank you.
Thank you, Erica. Now, before I introduce the speakers, I have a few housekeeping notes. Today's session is recorded and posted on the CDTRP website and YouTube channel. During the presentation, please keep your mics off. If you have a question or comment, you can raise your hand with the raise hand button or type it in the comment section. I'm pleased to introduce our presenter, Dr. Nicholas Murphy. Dr. Nicholas Murphy is a postdoctoral fellow in the Department of Medicine and Philosophy at Western University in London, Ontario. Supervised by CDTRP investigators, Drs. Michael Weir and Marat Slasarev, Dr. Murphy's research explores ethical issues in organ donation and transplantation, particularly as they relate to research with human participants. I will now hand it over to you.
Thanks, Stefan, and thanks for the introduction, and thanks to everybody for being here. I'm just going to share my screen. Yeah, so it's great to be here. Always an honor to present to CDTRP audiences. I feel that CDTRP was kind of the first home I found when I joined the organ donation and transplantation research community several years ago. So it's great to be here. Today I'm going to talk about empirical knowledge gaps and conceptual questions in the definition and determination of death in controlled organ donation after determination of death by circulatory criteria, or DCC. I don't have any conflicts to disclose. I do want to mention before starting out that although it's me presenting here, the paper on which this talk is based was a very collaborative effort among researchers with a range of expertise in Canada and the US. And it emerged from a workshop in March 2022 held at the National Institutes of Health in the US. And the workshop aimed to address the science and ethics of donation after DCC. So you'll probably recognize at least a few names here on the list, including Andrew Healy and Tennille Gofton, and Sam Shemy, all of whom have had some involvement with CDTRP. Sam Shemy was the leader of the subcommittee you see here in the authorship list. Within the NIH workshop, our committee was tasked with addressing the question, when is a potential DCC donor dead, and how can we be sure? And that's what I'm going to be talking about here today. And I think, as you'll be surprised to see, there are more knowledge gaps in this area than you might expect. But let me get to that in a while. This is kind of a longer talk, so I thought I'd give you a bit of a preview so you know what you're in for. In thinking about the goals of the talk, it struck me that it might be a little boring or a bit of a waste of your time if I were to just spend the whole time listing the research questions we list in our paper. You could just go download it from PubMed yourself. We ended up with about 25 research questions under 7 broad domains. So let me preface by saying that the real focus of what I'm going to be talking about is not going to be on listing a bunch of research questions. Instead, my focus is going to be on motivating the importance of this area of research as a whole, offering some background on it, discussing some obstacles to research, and exploring some of the conceptual challenges relating to particular areas of research in death's definition and determination in the organ donation context. I will definitely talk about some research questions, of course, but the idea here is more to describe the conceptual and research ecosystem in which this research needs to take place. So to start, I wasn't sure exactly how familiar everyone in the audience would be with the process of donation after DCC and death determination by circulatory criteria. So I thought, to be on the safe side, I'd briefly go over the timeline of a typical DCC protocol just to make sure we're all on the same page. Then I'll spend a bit of time motivating the importance of the topic by highlighting some reasons why it is really just surpassingly important to have a good science behind practices for death determination in the context of deceased organ donation. And apologies in advance, but I'm then going to briefly channel the philosopher in me by outlining important distinctions between a definition of death, the criteria for its determination, and the ways we assess those criteria. And I know that sounds a little bit pedantic, but really I do think it's a critical bit of scholasticism, you might say, that helps to underline what we're talking about and what's at stake when it comes to death determination in organ donation. I'll then highlight 4 of the 7 domains for further research that our group at the NIH identified as really important for further study. For each domain, there are a bunch of research questions, but my focus will be on discussing for each one why it's important, what we already know, and some of the things we still need to figure out. Okay, so let's start with the donation after DCC process. So patients who are candidates for organ donation after DCC are patients with a non-recoverable injury or illness supported by life-sustaining measures in the ICU typically. So again, typically unconscious patients who are supported with circulatory and respiratory support. These are patients who do not meet the criteria for death determination by neurologic criteria or DNC, but they generally have a serious brain injury. This is a population of patients for whom nothing more can be done medically and who unfortunately don't really have a chance of recovery to a level that they would want. So after the decision to withdraw life-sustaining measures has been made, surrogate decision makers are approached about the possibility of organ donation. After consent and workup, life-sustaining measures are withdrawn and the dying process begins, and the time that takes varies from one patient to the next. Once the patient's circulation stops, physicians wait anywhere from 2 to 20 minutes, depending on what country or jurisdiction you're in, just to be sure that circulation won't resume on its own. That's a phenomenon called autoresuscitation. Here in Canada, the wait period is 5 minutes. After that, the patient's death is officially determined and the transplant team recovers the patient's organs as quickly as possible. Why is there that hurry to recover the patient's organs as quickly as possible? Well, an important thing to keep in mind about donation after DCC is that after the withdrawal of life-sustaining measures, organs aren't receiving all the blood and oxygen they need to remain optimally viable. So they're damaged during this time. So basically, the organs aren't getting enough oxygen, nutrients, and sugars, so they're damaged. The damage that occurs during that time, during the dying process in DCC, often means that the organs don't work as well as the organs recovered from donation after DNC. At least historically, this was the case. It also means that there's only a small window of time between the cessation of treatment and following death determination in which viable organs can be recovered. If organs suffer too much damage due to lack of blood and oxygen, they can't be used. And that's, of course, a missed opportunity for transplant recipients who need a life-saving organ. And it can also be difficult for families of donors who want to see a successful donation. So DCC is a rapidly growing source of organs in Canada, and this is true internationally as well. In Canada last year, about 27% of all deceased donors donated via the DCC pathway, and 26% of all organs transplanted from deceased donors came from DCC donors. So very important source of organs. Okay, so now that we're all on the same page, let's talk about why it's so important to have a good science of death's definition and determination. Why is it so important to be certain that a donor has died before recovering organs? Well, there are many reasons for this, but a big one that we may be familiar with is the dead donor rule. This is the rule governing organ donation or deceased organ donation, stipulating that a donor must be determined to have died before organs can be recovered. The rule has a few convincing rationales. A big one is that need to maintain stakeholder trust in donation systems. So people may not be as willing to donate organs if they believe they're being recovered from people who are not yet quite dead. Simple as that. Probably more importantly, though, the dead donor rule ensures that donor welfare is not jeopardized. People who have died cannot suffer, they can't experience any harm. So mandating that donation only occurs after death determination is the surest way to protect donors from any harm. So you can see how if current practices for death determination have the potential to produce false positives, which would be determining a living patient to be deceased, both stakeholder trust in donation systems and donor welfare would be jeopardized. Not good. Particularly in the DCC context, there's another reason why having a sound science behind death determination is so critical, and this relates to organ viability. So I mentioned earlier how successful transplantation of DCC-derived organs is contingent on minimizing organ injury by limiting warm ischemic time. So if current practices for death determination have the potential to produce false negatives, which would be determining a deceased patient to be living, then organ viability and transplant outcomes, to say nothing of honoring the patient's donation wishes, all of these would be threatened because we'd be waiting longer than we'd need to before we recover the organs, and during that time they'd suffer additional damage. Again, not good. So in sum, top 3 reasons why it's critically important to have a sound science behind death's definition and determination: adherence to the dead donor rule, protecting donors from harm and maintaining public trust, and maximizing organ viability. Let's turn now to that pedantic distinction I warned you I'd be making earlier. Again, I think it's worthwhile to note this because it avoids some of the confusion we see in the literature around death determination, so please bear with me. So to make a death determination, you need at least 3 things. You need a definition of death, you need criteria for its determination, and you need tests to assess that those criteria are met. So one way to understand each of these levels is to just translate it and say, what is death? What are the criteria for determining that death has occurred? And how do you assess those criteria in actual practice? So let's take an example relevant to the Canadian context from the death determination guidelines published last year. In the context of DCC, the answer to the first question, or pardon me, the answer to the first question was death is the permanent cessation of brain function. In the context of DCC, the answer to this second question concerning criteria was sustained cessation of circulation defined as a pulse pressure less than 5 millimeters of mercury for a minimum of 5 minutes. And how do we assess this? Well, the guideline recommends invasive arterial blood pressure monitoring. Where that's not possible, continuous electrocardiogram monitoring. Importantly, the relationship between these 3 components of death determination is hierarchical. The ways we assess the criteria depend, of course, on what those criteria are, and the criteria themselves are informed by what the definition is. And what we need to keep in mind here is that the science of death determination can and should ask questions at each level of the hierarchy. So if you go back to the Canadian guideline, for example, at the definitional level, you can ask, well, what counts as a brain function? At the level of criteria, you can ask, how do we know that a pulse pressure of less than 5 millimeters of mercury reliably infers the loss of brain function? Or what is the lower limit that can lead to perfusion? And at the assessment level, you can ask, what is the accuracy of clinical monitoring in detecting arterial pulse pressures below 5 millimeters of mercury? Okay, so we've talked about the process of donation after DCC. We've talked about the importance of having a sound science of death determination and what the practice of death determination involves from a conceptual standpoint. And now I want to move on to discussing some of the domains of knowledge gaps that our group at the NIH thought should be prioritized for further research, and I'm going to address 4 of them. First, I'm going to spend quite a bit of time talking about, and the reason for that is in part because of that hierarchical relationship between definitions and criteria for death determination that I talked about earlier. The science of donation after DCC obviously is reliant on a definition of death because a lot flows from that definition. It's at the top of that hierarchy, and so it's a question to start with. It really influences things even like what questions are even asked, what questions are considered relevant for research or funding, and I'll talk a bit more about that later. But the research question here is both empirical and conceptual. What is the physiologic rationale for defining and determining death in DCD? And what are the conceptual implications for death determination frameworks? I'm then going to talk about the temporal relationship between the cessation of circulation and brain function. Then I'll move on to predicting time to death after withdrawal of life-sustaining measures. And then I'll finish with a discussion of normothermic regional perfusion and the potential for intracranial blood flow. Okay, so what is the physiologic rationale for defining and determining death in donation after DCC? And what are the conceptual implications of DCC death determination frameworks? Our group at the NIH started this with this question because we found during our discussions and in looking at the literature that the issue is actually far from settled, particularly in the US. So it might seem that it's a straightforward question, but there's actually a little more to it. The question is basically asking why? Why exactly does observing and confirming the permanent cessation of circulation mean that the potential donor has died? Here in Canada, the recently updated death determination guidelines answered the question in this way. So death is the permanent cessation of brain function. To have brain function, you need brain perfusion. To have brain perfusion, you need brain blood flow. So if all circulation in the body has stopped, you obviously don't have brain blood flow, you won't have brain perfusion, and therefore you won't have brain function. That's why confirming the permanent cessation of circulation means that the potential donor is no longer alive. So it seems simple, right? However, it's not so straightforward in the minds of some. And during our discussions, we found that this could be problematic for international collaboration for research. Now, there's some historical baggage to this debate that I think we should consider. So the American legal standard for death determination, called the Uniform Determination of Death Act, offers a framework for death determination where an individual can be declared dead when they've sustained either irreversible cessation of circulatory and respiratory functions or the irreversible cessation of all functions of the entire brain. So this is what came to be called either brain death or circulatory death. And the statute treats these as 2 equivalent bases for determining death, but it doesn't elaborate on any physiologic criterion that unites the 2 standards. So physicians came to determine what they came to call circulatory death, or they would determine brain death. They didn't just determine death. And there were 2 sets of criteria for each. Over time, there developed a really important distinction between these 2 standards, at least in the context of organ donation, and this has bearing on the issue we're talking about. Initially, when the legislation was enacted, donation after DCC was not practiced. There was only donation after DNC, or brain death. So the critical thing to enable organ donation at the time was to confirm that the loss of brain function really had been irreversibly lost before confirming death and proceeding to organ recovery. When donation after DCC was introduced in the 1990s, though, critics pointed out that even though circulation had stopped at the time of death determination, it could be resumed with medical intervention if you wanted to. So strictly speaking, circulatory activity was not irreversibly lost, and so obviously couldn't be confirmed. And by any strict reading of the statute, according to critics, the donors were not really dead at the time of organ recovery. So was donation after DCC consistent with the dead donor rule? Was it permissible? We don't have time to go into all the interesting and energetic debates around permanence and irreversibility here, but suffice it to say that there emerged from this debate an understanding or consensus within the donation community and the medical community more broadly, that the interpretation of the term irreversible within the context of circulatory criteria versus neurologic criteria should diverge. Within the context of donation after DNC, it remained critical to confirm that brain function had been irreversibly lost. That is, brain function was lost and it was literally impossible to restore it. By contrast, in the context of donation after DCC, there was a consensus that circulatory function need only be lost permanently. So that means that it had been lost, it would not resume on its own, and there would be no attempt to restore it for valid medical and ethical reasons. And this basically is the interpretation of the criteria for death determination on which the entire practice of donation after DCC is predicated. So, what is the source of the debate now over the conceptual apparatus of donation after DCC? Well, the definition of death we've chosen here in Canada is based on the permanent, not the irreversible cessation of brain function. That means that a patient can legitimately be determined to have died, even if their brain function could conceivably be restored to some degree with medical interventions. It's just that it won't be because this would not benefit the patient and it would not restore them to any meaningful life as they understand it. In effect, what we've done here in Canada is demonstrate that neurologic and circulatory criteria are just pointing to the same thing. So the conceptual hierarchy of the new guideline is usefully visualized as a pyramid with the definition at the top and the two sets of criteria and tests at the sides. So there are two pathways to determine that brain function has permanently stopped, and both pathways are subsumed under this unifying biomedical definition of death. As I mentioned, some critics do not buy this approach, and I think in part it's because they're accustomed to the idea that if you're paying attention to the brain, if what you care about is the brain in the context of death determination, then you should be thinking in terms of irreversibility instead of permanence, just because historically that's the way it's always been. In our discussions as a group at the NIH workshop, we came to realize that this confusion, this debate about how death should be defined and understood is an obstacle to international collaboration on donation after DCC research, as well as DCC research more broadly, with different camps, different approaches, and sometimes energetic disputes that aren't always the most collegial. Although I will say that our group was very collegial. It's more in the literature you see a bit of back and forth. And disagreements about the physiologic and conceptual basis for DCC death determination has important implications for the science because of that hierarchical relationship between definitions, criteria, and methods for assessing criteria that we talked about earlier. If, for example, you're operating under the assumption that the loss of brain function needs to be irreversible for the donor to be dead, then there would be no point in research into things like thoracoabdominal NRP, because the time required to achieve irreversibility is almost definitely too long for thoracoabdominal NRP to make a difference to organ quality. Obviously, we feel here in Canada that the issue is resolved, but the ongoing debates are a distraction that need a definitive resolution. We need to resolve the question to move forward with international collaboration in research, as well as harmonization of practices in DCC. Moving on now to some of the more tractable empirical problems we identified in this work. So this research question is one that is hopefully more of an exercise in reassurance. Current practices for donation after DCC assume, but they don't confirm the permanent cessation of brain function after that 5-minute observation period before death determination. Confirming that there's nothing going on in the brain is important for reassuring stakeholders that are concerned about the theoretical possibility that donors could be exposed to harm if they retained any degree of sentience during organ recovery. It's also true that if death is the permanent cessation of brain function, we need to confirm that brain function is well and truly completely gone reliably at the time of organ recovery if we're going to adhere to the dead donor rule and ensure that donors face no possibility of harm. I want to stress before going further here that the idea that donors retain any sentience at the time of organ recovery is very, very unlikely. But as we discuss in the paper, stewards of donation systems probably should address this issue to confirm that brain function is reliably lost at 5 minutes to reassure stakeholders. The assumption that it is lost is based on that sound physiologic rationale that we talked about earlier. So if there's no circulation, there's no brain blood flow. If there's no brain blood flow, there's no brain perfusion. And if there's no brain perfusion, then there can be no brain activity or function. But how long does it take to lose brain function after circulatory function stops? Or does circulatory function stop after brain function? We don't really know. There is some interesting emerging evidence showing surges of cerebral electrical activity following cardiac arrest in some clinical contexts that has given some stakeholders cause for speculation and a bit of concern. The surges appear to be quite common, and they appear anywhere from 30 to 360 seconds after the complete loss of measurable blood pressure, but their significance is unknown. They aren't accompanied by any form of brain function or consciousness as far as we can tell. Right now, the evidence for this sort of phenomenon comes from studies in resuscitative medicine and continuous intraoperative monitoring of patients with EEG during unexpected cardiac arrest. So this isn't a population that's exactly like candidates for donation after DCC. In research where patients have had neuromonitoring during and after the planned withdrawal of life-sustaining measures, so these are patients that are very similar to candidates for donation after DCC, studies with small cohorts do suggest that the cessation of brain function as defined by the absence of consciousness, isoelectric EEG, and brainstem-based apnea. This may reliably occur before the cessation of circulation due to progressive hypotension and hypoxia. That's reassuring. The problem, though, is that the overall evidence, body of evidence here is small. And most evidence, apart not this study that this graph comes from, but most evidence is indirect, and pediatric patients are underrepresented in studies that have been done. So everything we know for sure points to the idea that it's very unlikely that brain function persists at the time of organ recovery. However, direct confirmatory data from large studies using multimodal neuromonitoring would provide that reassurance that stakeholders need. I'm pleased and proud to be a part of an ongoing prospective multi-center observational study in Canada led by Murat Slesarev and Tennille Gofton that's directly addressing this research question we've been talking about by documenting the relationship between the cessation of brain and circulatory function during the dying process in the ICU. They're using multimodal neuromonitoring, including EEG, transcranial Doppler, brainstem auditory evoked potentials, and somatosensory event-related potentials. So stay tuned for the results of that study, which is ongoing. Okay, so let's move along now to a promising area of research that our group felt was important to address, and that's predicting time to death after withdrawal of life-sustaining measures in donation after DCC. Because of the problem of ischemic damage that I talked about earlier, the longer the dying process takes, the longer the organs are starved of blood and oxygen and nutrients due to that progressive reduction in oxygen and blood pressure, so the more they're damaged. Some organs, like the liver and the heart, are exquisitely sensitive to warm ischemic time. And for that reason, every institution that does donation after DCC puts a limit on the amount of time they're willing to wait before death determination. So a limit to the length of the dying process. These time limits vary by organ, so it's not necessarily an all or nothing thing when it comes to donation. It's usually 1 to 2 hours, but it's sometimes up to 4 hours if you're considering kidneys. There is a surprising degree of variability in these warm ischemic time limits across institutions. And in fact, there's no agreement at all on how the onset of warm ischemia should be defined. Some places, for example, start the clock as soon as life-sustaining measures are withdrawn. Others start the clock only when certain blood pressure and oxygen saturation levels are met. But whatever the limit at the institution, if the patient who's a candidate for donation after DCC does not die within that time limit, the donation has to be abandoned and the organs can't be used for transplant. Here's the problem. Because it's difficult to predict how long the dying process will take from patient to patient, depending on the institution, 20 to 40% of all donation after DCC attempts end up being abandoned because the dying process takes too long. And you can see how that would be difficult for everyone concerned. First, failed donation attempts are hugely resource intensive. There are personnel costs and infrastructure costs or time that's not used. There might be a transplant team traveling and assembling, getting ready, and so on. So that's a big use of scarce resources. But even worse, you could argue, is the toll this can take on families who have gotten their hopes up, expecting to find some meaning in their loss, only to have their hopes dashed due to the failure of the donation. And there's some really poignant qualitative research on the harms this causes to family members that really brings out the pain of that. From one study, being able to say, but look at the people he helped, or meaning, pardon me, this is covering, or hearing their stories, or seeing that they've lived and moved on, and that they have that quality of life, and hearing from the family just how it helped them. I think that almost lessens your pain and lessens your grief when you realize, okay, you're going through this, but there was that silver lining. So I think that because he wasn't able to donate, I think it's harder for my children and I, and it will be. If we had some way to accurately predict whether a patient would die within the institutional warm ischemic time limits, this could be avoided, or at least become less common. Physicians would be able to be more discriminating on whether to even approach substitute decision makers for consent to donation. And quite simply, it would save a lot of money and avoid harming families. There have been some predictive tools developed, but these generally only consider time to death within a 60-minute time frame, so they aren't useful for every context or every organ. None have seen a widespread uptake. There was a recent tool developed out of the DPART study using vital sign variability, clinical features, and physicians' prediction of a rapid death that shows promise. But again, this is only for adults, and its accuracy could always be improved. The big gap here is with predictive tools in pediatrics, where you can imagine the impacts of failed donation on families would be even more acute. So the NIH group advocated more research on this, including studies to better define the onset of warm ischemic time, research to better understand what patient characteristics are predictive of a rapid death, and how withdrawal practices might influence time to death. The last knowledge gap I want to touch on, at least in the presentation, is a very hot topic right now, and that's whether normothermic regional perfusion can lead to the resumption of intracranial blood flow. So a bit of a primer, NRP, or normothermic regional perfusion, uses extracorporeal membrane oxygenation technology to restore regional circulation after death determination in donors in donation after DCC. So basically, after the donor's circulation has stopped and death has been determined, a pump and an oxygenator are used to resume circulation in the donor's body, and that can help to prevent and repair the damage that organs sustain in donation after DCC. It also allows surgical teams the time to assess organ function. Although there haven't been any randomized trials of NRP, it does appear to improve organ viability, especially for the liver, and it also enables DCC heart donation, which was previously very rare and difficult in donation after DCC. Now, importantly, because in NRP you have oxygenated blood flow resuming not long after the patient has been determined to be deceased, the large vessels that supply blood to the brain are blocked, sometimes vented as well, to prevent the restoration of brain blood flow. So in thoracoabdominal NRP, surgeons attempt to isolate circulation to the thoracic and abdominal cavity, so that includes the heart and lungs. And in abdominal NRP, circulation is restored only to the abdominal organs. Now, particularly in thoracoabdominal NRP, where brain blood flow is blocked at the level of the great vessels rising from the aortic arch, there's some concern that blood could make it to the brain either through the failure of surgical safeguards or through collateral vessels, so all the little ones you see here. Clearly, that would be a very bad thing. First, although it's unlikely, there's a small possibility that the resumption of brain blood flow could lead to the resumption of brain activity, which could lead to brain perfusion and then brain activity, and also very unlikely, but still possible, brain function. That would expose donors to harm if they retained any degree of sentience or regained, and if brain function were resumed, that would also mean that the donor is technically no longer deceased, but in fact had been resuscitated, meaning that subsequent organ recovery would violate the dead donor rule with potential negative consequences for trust in the system as a whole. Again, not a good thing. Now, there haven't been any reports in the literature of brain blood flow resuming during NRP, but that really doesn't prove anything because neuromonitoring is not standard of care during NRP. There was one study with 2 donors with neuromonitoring that confirmed lack of flow, and a more recent study with 12 donors, 8 undergoing abdominal NRP and 4 undergoing thoracoabdominal NRP, that also confirmed lack of flow. So this is reassuring, but these numbers just don't prove anything. They're just not large enough to confirm that NRP is safe for donors. And that's a problem because NRP uptake is accelerating very quickly, especially in the US. And there's still quite a bit of variability in how surgical interventions to prevent brain blood flow are actually done. If we're going to move forward with NRP in Canada, it's critical that we undertake studies with larger sample sizes, with rigorous neuromonitoring in place to confirm that NRP is safe for donors in all cases, that it doesn't expose them to harm, and that it remains consistent with the dead donor rule. We need to know if NRP can lead to the resumption of brain blood flow. I'll finish by reiterating just a couple of takeaways from our NIH group's work. So first, the science of defining and determining death in DCC is critically important for protecting donors from welfare harms and ensuring adherence to the dead donor rule. Second, the science of defining and determining death in donation after DCC has a worrying surprising, and some would say worrying, number of knowledge gaps associated with it. And finally, because of the hierarchical relationship between definitions of death, the criteria for its determination, and the ways we assess those criteria, the international variability in the definition and determination of death is a hindrance to progress in this research area. So international consensus on the physiologic rationale for death determination in donation after DCC is something we should work towards. As the proportion of donors who donate via this donation pathway continues to grow, and as the practice of donation after DCC continues to expand internationally with evolving strategies to improve organ function, we think that strengthening the science of defining and determining death by circulatory criteria should be a research priority. Thank you.
Thank you for the excellent presentation, Murphy. Mm. I will now open the floor to any questions.
Oh, hey, Sam, you're an imposter.
Yeah, I wasn't sure why my name's Nick Murphy all of a sudden. I guess you've been so inspiring that truly emulating you.
I
Good
think I just
job.
sent you my link.
I think it was your link. Yeah.
Yeah.
Good job, Nick.
Thanks.
Okay, Linder.
Hi, great presentation, Nick. This really helped me more clearly understand all the issues for sure. It's very well presented. With some of the recent media attention, of course, that we've all seen recently, how do we convey a simple message, if there is one, to the public in understanding some of these issues? I mean, that's a big question, I think, but certainly
I know.
worth discussion.
I know just the man to ask. I invited Sam to join here. He was a co-author on the paper and led the subcommittee, and I know part of the DDD project addressed the death definition and determination guideline development project addressed just this question. So I'd invite Sam to comment on that if he wants.
Yeah, I think a couple of comments we've done through both Kimia Honorman's work out of London and Amy Sarti and Stephanie Sutherland's work out of Ottawa. We've done a lot more public evaluations and engagement than any other country has done in this regard. So, Stephanie and Amy were part of our death determining work and did systematic reviews of what the public perceives to be death, what the professionals perceive to be death. And then we created a instructional video. It's a 90-second video that really explains in simple terms with very useful graphics the physiological mechanism of a brain-based death, either arrest of circulation or primary brain injury. And they use those in focus groups in terms of what do you think that death is to you? And then showed them the video and then asked them again, now, what do you feel about it? We didn't underestimate the challenge of shifting people's understanding of death to the almost mythological status of the heart as the center of the body, to the brain as the center of body. And I believe this is going to be a process over time. But certainly in my presentations nationally and internationally, to academics, ethicists, philosophers, and the public, it certainly resonates in terms of a brain-based definition of who we are and when we end. The Kimia has done a lot of great work in terms of both, again, public and professional surveys, and now also an instructional video around normothermic regional perfusion with the public to help them understand. And what we hear from people who participate in these focus groups is, we don't care that much when you doctors say that we're going to die or we're dead. What we care about are we inevitably dying? Are you sure? And please make sure that I'm not suffering when I do that. And I don't care if you take my organs before I die. That type of sentiment is being expressed. But you're right, this US report that's 3 years old, by the way, and I'm not sure if there is a political motive to this in the States. There's no transparency of information. It certainly seeds people's uncertainties about things and breeds lack of trust. And all we can do is to be kind of focused on our job, which is create, with collaboration and representation across the country, the medical, ethical, and legal framework for the definition and determination of death. And make no mistake about it, we're not doing that, despite our interest in deceased donation. We're not doing that to promote deceased donation. We're doing it to, at all costs, avoid diagnostic error, because we know that cases like this in the States damage the donation and transplant system. And unless the people trust us and our colleagues in hospitals trust us, it's not going to work. And so diagnostic error is fundamental. Minimizing diagnostic error is fundamental.
Thank you. Great explanation. Those links would be great if we could see the videos.
Sure. How do we do that? I think it's in the
I think
it's in the
Katie might have
special
put it in.
supplement, right? Nick?
Yeah, I think it's on the DDD website, actually, or pardon me, the CBS website with the DDD. I can see if we can pull it up, but
Yeah, while you take questions, I'll try to find it and put it in the
Yeah.
chat.
I do have a question, Nick.
Yeah.
It's it seems like the definition of death as the permanent cessation of brain function. It seemed like I'm not sure the word to use. It restricted every aspect of death, or it reduced every aspect of death to just be brain death, kind of. So when we die for whatever reason, and then the doctor calls time of death, it's still just like it's been presented to be brain death. So the moment the circulation function stops and then the patient stops breathing, then it's just been understood to be, since there's no blood flow to the brain, then the person is dead, rather than the cause of death being maybe the person's heart got punctured by something, or the person had cancer and whatever happened. So it seems like every form of death or every kind of death can just be reduced to just being brain death, because since there's no blood flow to the brain, then that's why the person has died. Is that what I'm understanding?
Yeah, I mean, I think you have it right. I mean, that's the approach that we're taking here in Canada for a whole number of reasons, including a long period of confusion over what was really meant by what was significant about having these two separate standards for death determination, circulatory and neurologic. I wouldn't say that everybody's dead. Uh, I guess just to be careful. So if the heart is punctured, that would be the cause of death. But the person is dead because the brain has stopped functioning completely. Part of the reason that we want to move away from this language of brain death as well, we're not saying brain death, we're not saying circulatory death, we're just saying death. And death can be determined in different ways. Different things can cause it, but there's only one type of death. And I'm not faulting you by any means for using the language that's very, it exists in the literature and it exists in the media. But there were decades of the use of this language of brain death and circulatory death. And it led to confusion among members of the public, I think, into suggesting that there were somehow two types of death as opposed to one. And it speaks a little bit to kind of what I was trying to get at in the talk, which is because of this this bifurcated American standard that was enshrined in legislation, those standards somehow became reified, made real into somehow this notion that there are two types of death. So I think far from trying to radically alter the picture of what's going on with respect to death and death determination, I think the Canadian approach with Sam Shemmy's leadership is more of a clarificatory exercise to say, hey, it was always the case that these two standards and the sets of criteria associated with them were ultimately pointing to the loss of brain function, be it permanent or irreversibility or irreversible. And we're just making that clear now. So I think, as Sam said, there'll be quite a long process of sort of clearing things up a little bit. But yes, you have it right. I think that from a biomedical perspective, the emerging consensus in the international medical community, maybe with the exception of some professionals in the US, is that ultimately all death is brain-based.
Yeah, and maybe I can add, if you flip it around, cardiopulmonary resuscitation, it can be a dramatic life-saving intervention for people with cardiac arrest. But by far, the most common outcome of somebody who's had a cardiac arrest who's received CPR is oxygen deprivation, brain injury, and death or vegetative survival. The problem with calling it cardiopulmonary resuscitation is people think that the aim is to resuscitate the cardiopulmonary system. That is required, but that's not the aim. The aim is to resuscitate the cardiopulmonary system in order to resuscitate the brain. And if you fail to resuscitate the brain during CPR, it leads to death or devastating life-changing outcomes. If death or hypoxic ischemic brain injury and vegetative survival was the outcome for all cases of CPR, we would never do CPR, because the outcome is based on resuscitating the brain. And so not only is this work important, I think, in recentering away from the heart towards the brain in terms of defining death, it also is important, which is the next stage of evolution of intensive care. That is, rather than talk about resuscitating the heart and lung, we are talking about targeting resuscitation in order to reanimate the brain. And that's what we should be measuring during resuscitation, is the ability to resuscitate the brain.
Okay, thank you very much. That was well explained. Thank you.
I have a question, if that's okay. Thanks, Nick, for your talk. I'm a PhD student here at University of Toronto, and I'm working on a time to death model for my PhD for an infant population.
Wow.
So yeah, I'm writing the proposal now, so I've got lots of room for feedback. So I'm curious where you think current models fall short and what you hope to see in the future.
Well, I should have prefaced the whole talk by saying I'm not a scientist, but I read a lot of scientific papers for the purposes of this project. I think there are useful predictive models that are used in certain centers, and for whatever reason, there hasn't been widespread uptake of them. One of the reasons is they're limited by how many hours they're interested in, and they're not perfectly predictive, because I think one of the major issues is that withdrawal practices vary across institutions. So in order to develop a predictive model that's useful for your institution, you need to sort of replicate the withdrawal practices at whatever institutions form part of the development of that predictive model. So I think it's very, very, very difficult. As well, I suppose in the pediatric population, there's almost nothing out there. You are definitely far more of an expert than me on this, but certainly we need to go further than hunches. In our paper, we do talk about the need to explore whether withdrawal practices may impact time to death, and whether there are certain withdrawal practices that could lead to a more predictable trajectory toward death. However, then you raise the question of whether altering withdrawal practices in the interest of facilitating donation is legally and ethically permissible, and in what sense it might be hastening death. I think Sam can jump in here as well.
Yeah, I mean, Nick's absolutely right. As part of the D-PART study that studied 650 adults after withdrawal in a multinational observational study, there was a subgroup analysis of time to death and predictors of that. It was led by Jason Shaheen here in Montreal. In that study, what was shown was, in the entire cohort, and this is in 3 countries, in Canada, the Czech Republic, and the Netherlands, that 80% of all patients had all supports stopped within 15 minutes. So-called abrupt cessation of all supports. So you extubate, you stop cardiovascular supports, etc. But Nick's right. In some places, some people might wean supports rather than stop them. But the standard of care seems to be abrupt stopping of all supports at once. in that cohort, it was clear that if the time to death is shorter if you stop all supports at once, as opposed to weaning mechanical ventilation over time or weaning vasopressors and inotropes over time. So, and the question is, if standard of care in 80% of patients is stopping everything at once, if you have a DCD consented patient, you are not helping the process if you're weaning rather than stopping, in terms of a family who's motivated to donate. And the other thing it showed was that there was really no difference in sedation, analgesia, palliative care management at the end of life, regardless of how you extubated. So the important predictor of time to death is stopping everything at once, versus weaning. But once you do that, it's hard to predict in each individual patient. And anybody who's a clinician never predicts, because you say it might be minutes to hours to days. We're never sure. What is clear is if the patient has no drive to breathe, they will die quickly. But if there's an intact drive to breathe, then it's hard to know. And all the and Sunny Denani and the group has this donation advisor software program to try to help predict time to death. All the studies have shown that variables of the patient in predicting the time to death are no better than an experienced clinician predicting the time to death. But there must be a better way to do that. But I doubt it, if I can put it that way, based on the existing studies. So it'll be interesting, Katie, your work it's in the neonatal population or the pediatric population?
Infants less than 1, so kind of both.
Sorry.
Yeah.
Yeah. So and so it'll be interesting in that particular cohort, but I would imagine that the most important predictor is whether they have an intact drive to breathe or not.
Yeah. Thank
and
you.
the level of vasopressor support that they require if they're.
Thanks.
I see that our time is about up. So thank you for the questions and the comments throughout today's presentation. Dr. Nicholas Murphy, on behalf of CDTRP, thank you again for presenting. And if anyone has additional questions, comments, or suggested topics and speakers, please contact Erica Croft at ekcroft@cdtrp.ca. Thanks, everyone. Enjoy the rest of your day.
Thanks very much. Bye-bye.